To our webinar, Peer Support in the Private Sector, Careers in Private Practice. My name is Kelly Davis. I'm the Director of Peer Advocacy, Supports and Services at Mental Health America International Office, and want to introduce you to our two presenters, Patrick Hendry and Amy Farrington. Before I do that, just to mention, if you are logged on, for folks, if they could please mute their lines, and then if you are having difficulty logging in or hearing for some reason, you can message me directly in the message box. We'll also be having 30 minutes at the end for Q&A for folks to answer any questions you might have. So I'll introduce Patrick. So Patrick Hendry is the Vice President of Peer Advocacy, Supports and Services at Mental Health America. He's worked as a mental health advocate for the past 24 years. His areas of expertise include peer-provided services, self-directed care, recovery-based training, organizational development, and management and sustainability. He's the former executive director of the Florida Peer Network and has assisted in the development of numerous peer-run programs and organizations. Patrick is a strong supporter of the inclusion of mental health consumers in all aspects of the behavioral health system. Amy Farrington is the Director of Certification for the Florida Certification Board. Since 2006, when she joined the FCB, she's been responsible for the development and administration of all facets of FCB's professional certification programs. Prior to joining the FCB, she served as the Director of Education and Training at the Florida Department of Children and Families. Ms. Farrington holds a master's degree in instructional systems design and brings over 18 years of statewide and national experience developing and administering professional adult education, training, and certification programs to the project. And I'd like to turn it over to Patrick to get started.
Thank you, Kelly. Can you hear me now?
Yes, I can hear you.
Okay. Well, we're going to talk a little bit about the future of peer support, but the main purpose in this is to really talk about moving into a brand new area for peer support, and that is the private sector. And I don't have, there we go. So in order to talk about the future, I think we need to talk just a little bit about the past. And peer support goes back as far as recorded history. People have supported each other in times of battle. During the 18th century and 19th century, Native Americans created support groups for people that had become addicted to alcohol. But the modern use of peer support, where it's formally introduced into a mental health arena, really started it's very slow, sorry about that. It really started in France in the 1700s, and a hospital in France, the head psychiatrist and the director of the hospital decided that it would be of value to hire recovered patients to work as hospital staff. And so they did, and they were praised by the governor of the hospital as being gentle, honest, and humane. They were against active cruelty and disposed to kindness, in the director's words. So it sounds kind of familiar to us, I think, in that that's what we hope for peer support to be now. That hospital was being run by a director who was a Quaker, and it's not changing. Doctor named Benjamin Rush learned about this system while he was in Europe, and he came to America and was a doctor of what we would now call psychiatry. He was actually one of the founding members of the American Psychiatric Association, and he was also one of the signers of the Declaration of Independence. But Dr. Rush was a member of what was had started off as a Quaker movement and then had moved throughout care into hospitals around the United States. And this movement was picked up for compassionate care. And this movement was picked up by a very famous American woman named Dorothea Dix, who went on to form these hospitals around the country. And so for the later parts of the 1800s, the U.S. had a very compassionate system of hospitals where the day was dedicated to work and healing, and that if people were treated humanely and with respect, that they would begin to heal quicker. Unfortunately, that began to change right around the turn of the century, and we began to have these mass asylums and psychiatric hospitals around the country. This is a picture of a state hospital in Philadelphia, or in Pennsylvania, called Byberry Hospital. This is 1946. Hundreds and hundreds of people were kept in this hospital. And you can see this is a picture of the day room where the men were kept nude and with urine on the floor. So we had really gone from this Enlightenment era of the previous 100 years into the darkness of the early 20th century. In about the 1960s, a movement started around the United States, and it was mainly started because states were beginning to realize that running these huge hospitals, which often had thousands of people in them at one time, was both expensive and it didn't work, and there were constant issues of cruelty and inhumane treatment that came up. So this deinstitutionalization movement began in the 1960s. And they began to shut down the asylums. In 1955, there were 550,000 people in state psychiatric hospitals. There's currently about 50,000, and maybe that's even too many. When people came out of the hospital, a lot of them were very angry. And one of the things that happened as they began to close these hospitals down was that the money that they saved didn't go into the communities to provide people with the kinds of supports that they needed. So the very first people who came out were very angry and didn't want to be a part of the mental health system, and they referred to themselves as ex-patients or survivors. And when they said survivors, they meant they survived the system, not their diagnosis. Right around the end of the 1970s and the beginning of the 1980s began a time that we refer to more as the consumer movement. And this is when people living in these communities without a lot of services decided that if they were ever going to make meaningful change in the mental health system, they needed to be a part of that system. And so that was the beginning of the consumer movement. And On Our Own of Maryland is the oldest consumer-run organization in the United States right now. And this was a drop-in center in 1983. There were a few others starting up around the country. Some of them were called drop-in centers. Some of them, even on the West Coast, were called freak-out centers as part of the survivor movement. Peers began to work more and more through the 80s and into the 90s. And as they did, they began to realize that they were the change agents. By working inside the system, they had much more effect on humanizing the system and beginning to have people treated with more respect and for services to actually be more effective and more meaningful. And it's not changing. There we go. So in 2001, as this movement began to continue to grow throughout the late 80s into the 90s, in the early 90s, we didn't even use the word recovery in the United States. There was some people in Europe were beginning to talk about mental health recovery, but we actually started to use the word in the very late 90s and even be given the sense that there was a chance for most people to recover. Georgia, in 2001, created the first peer certification for certified peer specialists, and this was groundbreaking. People had been working in peer support services, but they really weren't very well trained. There were no really organized trainings going on around the country. There was very little opportunity for people to have jobs. A community mental health center might have a couple of peers that worked in the center, and very often they were in very menial jobs. For instance, if they drove a van to pick people up and bring them to their appointments, sometimes to deliver medications for people. Sometimes I even remember when I first got involved in the system in 1990 and started and worked very briefly in the community mental health center, we worked in day treatment. And the activity that the peer staff was given was we would help the people in day treatment to make popcorn or cookies, and then they would go around the community mental health center and sell them, and they thought this was the best use of our time. That all changed when Georgia began to create this system. And it mostly comes down to a single individual, a guy named Larry Fricks. Larry was the director of consumer affairs for the state of Georgia. And Larry believed that this could be organized, that we could have really good training, and that people could begin to build careers in the mental health system. In 1999, Georgia also was the first state to be able to bill Medicaid for peer support services. So peer support over that period of the 80s and 90s up to around 2000, and even now today, has found a real home in the community mental health system. So in community behavioral health, peer specialists have all kinds of roles. Some work in inpatient roles, some work in outpatient roles, some in peer-run organizations, some directly for hospitals or community mental health centers. Some even work in integrated care settings when you integrate primary care and behavioral health. But there really was very little chance for people to go beyond that. There are currently about 30,000 certified peer specialists in the country, plus approximately 10,000 in the 5 states that don't have certification. California alone has over 6,000 peer support specialists working without certification. Currently, in the public behavioral health system, full-time pay for a peer support specialist, a certified peer specialist, averages around $16.50 per hour. So far, though, we've really met with closed doors when we've tried to move beyond that public system and into the private system. And there's a couple of real good reasons for this. The main one is the funding barriers. Community behavioral health is paid for generally by the state, often with Medicaid dollars, but it doesn't have any way to pay for people to receive treatment in the private sector. Private health insurance has been reluctant to take it on, and also Medicare. Even though Medicaid pays for most of the peer support work done in the country at this time, Medicare still doesn't pay for it. And so until those things change, it's very difficult to get our feet on the ground in the private system. The reason why private insurance and Medicare don't really support this yet, even though they're talking about it, they're interested, is because we have 45 states with certification. Each state has its own qualifications to become certified. And these can vary tremendously from state to state. So there's a lack of consistency for a national healthcare organization or something national like Medicare, which is the largest healthcare insurance company or insurance service in the United States, if not in the world. The other thing is that there's been a real shortage of reliable research. In 2007, Medicaid declared peer support services as an evidence-based practice. And this opened up a lot of doors for us, and a lot more states were able to begin to pay for peer services through their Medicaid systems. Medicaid is a combination of federal and state dollars and is generally run by the state under federal guidelines. But we haven't had a lot of academic research, and that's what especially the private health insurers have been kind of waiting on, and also the private practitioners. The door is beginning to open. A lot of the health insurance companies are looking very closely at peer support, and some are even beginning to start up some pilot programs. And so some of the reasons why is because they're seeing the outcomes. In the 1990s, late 90s, and throughout 2000s, a lot of Medicaid services moved from fee-for-service, where you went to see your doctor, to see your therapist, and then they would bill the system and get paid directly by Medicaid through their agency. So that was called fee-for-service, and it wasn't real efficient, and there was no way to control the kind of outcomes that people had. If you just said you spent the amount of time, then you got paid the full amount of money. So there was this very strong movement, particularly in the mid-2000s, to move Medicaid services to managed care. Managed care was a little scary for the consumer movement at that time because it sounded like they would be taking away dollars from services and providing them to these companies that would then run services. So it was like another layer of funds being taken off the top. But in reality, managed care in many places has turned out to be very beneficial to the peer community. And that's because one of the main reasons is they keep really good records. So we're now able to prove how well peer support works. We can measure that people report a higher quality of life when they receive peer support, that they have increased treatment outcomes. They do better. They work on their own health care. They're involved throughout the system very frequently because they feel ownership. And managed care has done that by putting peer support as an integral part of the services they offer. Now, this isn't quite happening in every state yet, but it's growing very rapidly. We know that when people have access to peer support, there's a lowered rehospitalization rate. So if we have peers working what's called the Bridger model, where the peer goes into an inpatient setting, meets the individual who's going to receive their services, begins to build a trusting relationship with them, and then follows them back into the community and continues to support them. We know that people who get that type of service have dramatically lowered rehospitalization rates. We also know they have dramatically lowered emergency room usage. And the other thing that really says a lot to the funding agencies is that we know that there's a decreased cost of services when you bring peer support in, because peer support is able to fill in a lot of the gaps that the traditional system hasn't been able to fill. And so people who, for instance, people had long wait times, and so it's a very inefficient system. We've been able to fill in those wait times with peer support. We've also, like I said, been able to follow people into the community. Instead of people having to go to a centralized location, the services came to them. So by decreasing the cost of services, we allow more people to receive services because the state or Medicaid are going to spend the same amount of dollars either way. And so if it's more effectively spent, then more people can get services. In pilot programs with some of the healthcare organizations, private healthcare organizations, the pay scales have averaged about $20 an hour. So that's a significant increase over the average of $16.50 in the public system. And I think that the private system wages are going to increase more and more as it becomes more competitive for agencies to be able to hire really well-qualified people. So as we begin to expand into this private sector, some of the barriers that we now face with private practitioners are the same ones that we encountered when we were trying to break in to the public health system. So some of that is the fact that peer support is still a new concept to the private sector, just like it was to community mental health in the 80s and 90s and even up to 2000. There were many community mental health centers that had never had any experience with peer support. Well, that's what the private sector is facing now too. It also, when you bring a new service, particularly one that changes the whole ball game, like peer support, it requires that the culture of the organizations where peer support is being introduced change to a different point of view. By including peers in services, systems tend to change to a more recovery-oriented focus rather than maintenance and reduction of symptoms, but really helping people to achieve the life that's meaningful to them in the community. It requires that staff set aside existing stereotypes about what it means to be mentally ill, because almost inevitably, when you first begin to introduce peer support, whether it was in the public sector or now in the private sector, many of the staff members had real suspicions about the ability of peers to work effectively. They were worried about people having relapses. They were worried about peers being able to maintain confidentiality, which is kind of ironic because if anybody's interested in confidentiality, it's somebody who's been in the system themselves. So they've had to set aside their ideas from mental illness, which is an illness model, being something that takes over a person completely, and maybe there was never any hope of recovery in the first place. I know when I was diagnosed, and I'm sure many of you went through the same experience, because it still happens, I was told You have a mental illness. You'll always have a mental illness. You have to take medication. You will always have to take medication. You'll probably never work again, or if you do, it's going to have to be something very low stress. For me, all of those things have proved to be false. And the way I've learned about the true nature of recovery was I was very lucky early on in beginning to get involved in mental health. I met some peers who really did believe in the power of peer support. It also is a bit of a leap for people who have gone through school, have maybe graduate degrees, have worked in clinical roles for many years. It's been hard for them to accept the role of a peer as having authority as a provider of mental health supports. And so staff has to refigure out, what does it mean to be a peer? And what we say that it means to be a peer is that the very fact that we have that lived experience, that's our advanced degree. So what's been happening over this last 10 years or so is that in our own way, we're starting to professionalize peer support because we're increasing knowledge. So those states that have these different levels of knowledge required to be certified are beginning to provide better trainings. And there's a lot of different trainings around the country. We're requiring higher standards, both in knowledge base, but also in experience. And we're constantly evolving. You know, we've been very lucky in the peer community. Since 1984, there was a conference every year that was sponsored initially until last year, sponsored by SAMHSA, called the Alternatives Conference. And this was a conference put on by peers for peers. And out of that conference, over these 20-some-odd years, or 30-some-odd years, people have learned to introduce new ways to use peer support, to work with people so that they become stronger. You know, there's a concept called shared decision making, which has existed in medicine for a long, long time, but it was almost never utilized in mental health until peers got involved. And the basic issue of shared decision making is that the individual who's receiving the services and the person who's providing the services work together as a team so that people own their own outcomes. They own management of their own symptoms and treatment. So we've constantly been evolving throughout this period of time. And our trainings have gotten way more significant and way more in depth. I mean, we now, originally we looked at listening skills and, the ability to form trusting relationships and advocacy skills, primarily originally self-advocacy and some systems advocacy or second-person advocacy. But now we look at things like activation. Peers are particularly good at working with people who maybe have been very reluctant to go into the mental health care system because it's scary, or maybe because they had bad experiences in the past. Peers are able to go talk to people on a real level where they're sharing information back and forth. And we call that activation, because when a person realizes that they can have a say in their own self-management, they activate themselves into this whole process. And now they can see if things are working out for them. And now they have hopefully the respect of their psychiatrist or their therapist or their case manager. They have the respect enough from them to be able to participate in the decision making. We teach people how to make hard decisions. It's difficult to do changes in a person's life. Change is scary. We also teach very strong ethics and boundaries scales for people to work under, because this is a profession. It's a certified position, just like many other positions in the country are today. People who have traditionally been in clinical roles. Peer support is not clinical. Peer support will never be clinical. It's very difficult when somebody goes to work and they're the only peer in a very clinical environment to resist that tendency to think of things in more clinical terms. But that's not what we do. What we do is support people, and we work together in partnership with them to figure out how to achieve the goals that person wants. So by increasing our knowledge base, we really change the evolution of the profession by changing the evolution of training. So, as I said, one of the reasons why private funding and Medicare is still reluctant, or was particularly reluctant, to begin to fund peer support in private side was because of this lack of consistent standards across the country. So in 2015, Mental Health America, we began to work on this idea, and we worked with our next speaker, Amy Farrington, about to create a national standard, a national certification. Now, this was never meant to replace certification. It doesn't compete with state certification at all. In fact, if you work in a state that has state certification, we require that a person be certified in their state before they go after the national certification. It's really meant to be an advanced degree, and it's meant to say to private practice, look, if you hire somebody in Florida who has this national certified peer specialist credential, and you hire somebody in Washington State who has that same credential, you're going to get the same quality of care, the same knowledge base, the same degree of experience. And Amy's going to tell us a lot more about that in a few minutes. There's a man named Ron Manderscheid, and Ron is the executive director of an organization that represents county mental health directors and developmental directors around the United States. It's a very large organization because it represents all of the counties in the country. He is also a professor at Johns Hopkins, and he used to work for the National Institute of Mental Health. And Ron is brilliant, and he's been somebody who has been a friend to the peer movement for many decades. Ron has been saying over the last few years that he believes in the next 5 to 10 years, the behavioral health workforce, which is currently 420,000 people in all the various kinds of roles that you can have in behavioral health, he believes that the percentage of peers in that workforce is going to grow to 20 to 25% of the entire workforce. Just with today's numbers, that would mean we needed a peer workforce of 84,000 to 105,000. And as I said before, we currently maybe have anywhere from 30 to 40,000 people working in these roles. So there's a lot of room for growth. And the interesting thing about that is that's just in behavioral health. Because one of the other things that we've really learned through our experience is that peer support is universal. Everyone needs peer support at some time. And sometimes it's very informal and sometimes it's formal. But we know that people with diabetes and heart disease and living with breast cancer and all kinds of serious health challenges benefit when they get peer support. You know, when I was growing up, I was a teenager, and my mother had breast cancer. She had a double mastectomy. For the rest of her life, she held support group meetings in our home for other women. I grew up in a military family, so other women who were living on the military base wherever we would be would come to our house to share their experience and talk about things, and particularly for some of the younger wives who were very afraid. And, you know, these things weren't talked about back then. This was in the 1960s and 70s. So, you know, we know that peer support can work for everyone. And so what we want to do is utilize our knowledge, because in behavioral health, we created a real system for training people and certifying people and supervising people. And so we're really interested in seeing that change to become peer support available to people throughout healthcare, but people who are really well trained. And many of us, you know, have co-occurring disorders of all different kinds. You know, diabetes is very prevalent in the mental health community, and substance use we know is very prevalent. Heart disease is very prevalent. And there was a study about 10 years ago that came out that said that people who live with serious mental illness. And I don't like to use that word illness, but it's the language that most of these things come out in, because it's not the same as other kinds of illnesses, and we know that. But anyway, that people with serious mental illness or serious mental health disorders tend to die anywhere from 10 to 24 years earlier than the average population of the United States of America. And we're beginning to understand some reasons for that, and a lot of it has to do with, some of it has to do with symptoms, and so it has to do with isolation and feelings of exclusion. It has to do with the fact that some medications really promote tremendous weight gain for people, which creates a myriad of health problems. So peer support, one of the other changes that's happened in the last 10 years is that we've begun to look at whole health peer support so that we work with people. So, probably out of the 30,000 certified peer specialists in the country, we probably have at least a third, if not half, of those certified peer specialists living with some other serious health condition that they could provide support and meaningful support in that area. So the future for peer support has tremendous opportunities. The need for peer support, if we look at all of healthcare, is actually in the millions. So as we begin to build out this workforce of people around the country so that people can find support no matter what door they walk through, we will need this ever-increasing number of people who can knowledgeably and capably provide that kind of support that has saved so many of us. And we're not just talking about jobs, we're talking about actual careers. And that's something that's been largely denied us too. In community mental health, most people come in and they're hired as a peer specialist, and they stay basically at the same level as long as they work in that community health setting. Sometimes they move on to supervisor positions, or sometimes they become trainers, but mostly it's static. And the other irony has been that wages have been pretty static too. In some states in the United States, peer support is paid for at minimum wage levels, and in some places it's paid for considerably higher, like in New York State, which has really brought their peer support networks really up to a high standard. And so therefore, people are paid higher wages there, and some other states too, including California. So think about what that would look like if we started to be able to build careers, and that you could come into this job and then grow in the job of peer support. And it doesn't mean that you keep on doing the same things. Just because we come into work in a peer position doesn't mean that we can only have that type of position. It doesn't mean that we can't advance through a variety of roles. Peers, many of us, particularly people who began to have problems with their mental health a little later in life, have often had meaningful careers in the community before they maybe moved into disability for a period of time. And then they come back out through the peer support role, but they still have all those skills. And I have seen peers now, and I'm sure you all have seen them too, peers working in a whole range of jobs, not just in peer support jobs, but in administrative roles and executive roles, throughout supervision roles and training roles. And they have this extra added value to those roles because they have the peer point of view. They've lived through this, so they know how important it is to provide these services at the highest quality possible. So I think for peer support as we go forward, one of the things is that we continue to do our work because it's critical work, and it not only improves lives, it saves lives. And we continue to learn throughout our career, and we continue as individuals to grow. And one of the best ways that I found to grow has been my work in supporting other people, has been as beneficial to me, or maybe even more beneficial to me than the people I support. And then the final thing that we hope that people are able to do is move into this state that positive psychology refers to as flourishing. And it's a state where people, whether they have a diagnosis or not, they experience positive emotions and positive functioning. And that doesn't mean that you don't have down times or times perhaps when you may even need to be in the hospital or under more strict type of care. And they have positive social functioning. You know, we need to get people out of exclusion and into inclusion in our communities and our neighborhoods. And so that's, I think, the next step in peer support is to begin to look at our roles in helping people to not only move into recovery, but to actually flourish and continue to grow. So thank you very much, and I think Amy is going to pick up from here. And we'll take questions at the end.
Thank you, Patrick. Hi, everyone. This is Amy Farrington. And although I have a lot of what I like to refer to as fantastic skills, computers are not the best. So bear with me as I see if I've got this together. I think I do. Alrighty. Well, I'm really happy to be here and talk to you guys. What I'm going to talk about is to build upon what Patrick was sharing with you about the program, the history, why we need it, really from a credentialing and a measurement perspective of why a national credential that's been built to meet validity, reliability standards, a legally defensible credential was really necessary. The other thing that I would like to do as well is just address for a second why Mental Health America is partnered with Florida Certification Board. I know that there's a lot of questions about that, what's Florida doing, and it really does go back to Patrick's personal history and professional history. When I first started at FCB, it was 2005, 2006, and we had been approached by the department to build the nation's first, what I'm going to refer to as bona fide credential. And by bona fide, what I mean is that it meets national benchmarks for quality programs. It's equivalent to licensure. It's not a point-in-time training or a credential. It's something that looks at someone's history, their work experience, their training, their knowledge base, the ability to pass a test, and then folks are under a code of ethics and continuing education. And so at that time in 2006, again, there were no credentials throughout the state, so Florida started to develop one, and Patrick was one of the subject matter experts that I got to work with. So we've been together in the peer space, him much more advanced than I do, but I in the measurement point really for the last 12 years together. And so when Mental Health America made the decision to build a credential to support this program, Patrick reached out to me and said, Amy, can you do this for us? And I said, oh gosh, Patrick, there is a lot of liability associated with this, but it's really exciting. Let me see if my company would partner with us instead. And so that's truly the long, sordid story of how FCB got involved. We are the vendor to Mental Health America, but we also bring 30 years of experience in developing and implementing certification programs in Florida and across the state. So that is why I am here with you. All right, but again, like I said, because FCB is a professional credentialing entity, we had to ask a lot of questions to really make sure that this was something that we wanted to get involved with besides the feel-good nature of what we knew we had been doing. So we asked ourselves, we asked the field, is there a need that is not currently being met? And what we found, as Patrick shared with you, is there's over 40 programs across the country, but they're all at the state level. They're all varied. And so we identified that, yeah, there probably is, what's not being met is a national standard for peer services. And then we said, well, is there something besides certification that can go ahead and fill this need? A lot of times folks need training. They don't need the full credentialing process. But to go hand in hand with a lot of what Patrick was talking about, when you're moving from the public sector where peer services are respected, valued, and incorporated as part of the overall system of delivery and includes funding, we're still trying to get the private sector to understand that. And there's a lot of assurance that comes to private sector payers when you can tell them this person is certified, they've passed an exam, they're under a code of ethics, they have the education and experience that you can trust in order to reimburse them for services in the private environment. We then went into, is there a target population that's involved in the practice of peer support that would benefit? And again, our answer to that was yes, because, and again, I don't want to sound like a parrot, but I'm probably gonna. As Patrick said, peer support's been evolving over the last decade and a half, and we need different levels. One thing that I really want to make clear to everybody is there is room at the table for everybody. From the person who wants to provide peer services, much like Patrick described his mother doing, reaching out to other people, providing support networks, all the way up to our, entry-level peers who have training and some experience and are starting to reach out. And now we're at the point where there really are folks that have been doing this for a long time. They've got advanced skills. They're able to take their lived experience and apply it within other healthcare teams like private healthcare. And so we felt like the answer to that was yes as well. I'm hitting my button instead. All right, so we then looked at what are the characteristics of this prospective population, who produces individuals with these skill sets, who employs them, who pays for their services. And for each of these questions we found, and I'm sure not a huge surprise to you guys, that there are a wide variety of characteristics of people who come to the table. But our shared characteristic is, in fact, having that lived experience and the desire to help others achieve and maintain recovery through sharing life experiences and learn knowledge. But outside of that, there's a wide variety of characteristics. There's a lot of different entities, be they national training groups, statewide training groups that produce folks with these skills, and lots of employers, but unfortunately who pays for their services. Right now, it really seems like it's dedicated to the public sector, and we really felt like when you went through all these questions, the people were there, the training was there, the need was there, and we're now at the point where we want to say to these payers, look, this is someone who is qualified, who is reliable, who you can count on to work under a code of ethics where your consumers are safe, and someone who wants to be in this field because they're continuing to engage. So because we got yeses all the way through this, we said absolutely there is a need for a national certification, and we went forward. So I'm going to talk to you guys about how we developed it. Again, this is about the competence and the process that we used. But before I get into the slide, one thing that I want to say straight up is some of the pushback that we received across the nation was that this project was not very peer-y. You're not doing peer work. You're moving away from the fundamental basis of peer support. You are operationalizing it. It's not done by peers. And what I want to tell you all the way from Patrick to myself, this entire project has been peer conceived and peer developed. There was an article that was written by NACABID, the National Association of County Behavioral Health and Developmental Disability Directors, about this, and I'm going to read to you their paragraph. It says, the group that's been putting together the new credential is something of a who's who of peer support. In addition to himself, Hendry says the group includes Larry Fricks, Joseph Rogers, Sue Bergstrom, Tom Lane, 4 working peer specialists, 2 working peer supervisors, a private practice psychiatrist, a psychologist, a primary care doctor, and a social worker who are all peers, as well as a psychometrician and the lady talking to you right now. I was diagnosed 20 years ago, and I'm continuing to live in a wellness and recovery fashion. And so I do want you guys to have the confidence that We are you, you are us, and this was built for us. It is about us, and it's going to continue to help folks also move into recovery and wellness that we know is possible. So that being said, FCB does follow the Institute for Credentialing Excellence national credentialing standards for quality certification programs. One of the things that I like to describe is they are my my Good Housekeeping blue seal of approval. I've got somebody else overseeing every step that FCB takes when we build a credential to make sure that the resulting product, again, like I said, is valid, reliable, and legally defensible, whether you're becoming a peer specialist in Altoona, Pennsylvania, or in Los Angeles, California, or in Weehawkenee, Florida. So our process has got to be valid, it's got to be reliable, it's got to be legally defensible. Your private pay folks need to know that if they're reimbursing people for peer services, no matter where they are, that they have that same core competency that they can count on. This group also ensures that our program development, administration, and maintenance meets national quality standards. So it's not just how we built the program, but it's also how we implement it and how we maintain it all along. Again, we are FCB as the vendor to Mental Health America, and our primary role is to make sure that all of the exam instruments and credentialing tools really reflect what you expect out in the field, both from an individual seeking the credential and from individuals hiring credentialed folks and receiving services. We also wanted to not, as I said earlier, ignore any of the phenomenal history of peer support, which quite frankly has led it to become an evidence-based practice. It works so well that we need to put some parameters around it. But we didn't want to throw out the baby with the bathwater and, again, really acknowledge what's happened. So we started developing these core competencies by integrating all of the existing best practice standards, guidelines, and principles in peer support that you're very familiar with. Our two primary documents were out of the Substance Abuse and Mental Health Services Administration, their peer competencies, as well as the guiding principles from iNAPS. So that's where we started. So again, like Patrick said, we're not taking anything away. We're saying folks have already gotten to this level. Anybody that's interested in the next level, we're now going to jump off from this starting place and saying everything you've done is so important. Let's go to the next place. There is a very recent publication that came out that you guys might find of interest. It is called Mental Health Leading Practices for State Programs to Certified Peer Support Specialists, and the link to that final report is there. What you will see is that the folks who conducted this survey and research spoke with Mental Health America, they spoke with ICRC about their entry-level peer credential, and to several states who had some really emerging and best practices in peer certification, and I was really proud for our program to be part of it. Again, this is one of the newest documents supporting what we're doing as a profession as a whole and where we're going, and I thought you might find that interesting as well. Alrighty, so let's talk about the credential itself. Now that you know that I've got somebody else overseeing me and that this can stand up to a court challenge, it's really not Amy making stuff up in her corner office. So what we said was we are building an advanced credential, which is designed to build upon and enhance traditional peer specialist training and competencies that are upheld by your current programs and add the additional competencies necessary to enable peers to work alongside any other healthcare team. So again, we're still looking at advocacy, we're looking at mentoring and learning through shared experience. But what we have now is also a domain on the foundations of healthcare and foundations of activation and how you bring these competencies into this healthcare environment. And again, it was purposefully designed to remain true to the fundamental principles and to the core values of peer support services while expanding its concept and demonstrating its effectiveness to new markets, particularly the private healthcare industry. Now, something I'm really proud of as well, in addition to that who's who list that I shared with you out of the article written out of DC, one of the people that was on the team was also an actuarialist with Kaiser Permanente. And so that means this is the person who's looking at the standards and the qualifications for the type of people, the types of folks that Kaiser Permanente will reimburse for. And so Andrew was also on that team. So it's not that we're just hoping that we've got stuff that people would like. We have an email that I actually have taped to my wall where Andrew said, I like and am very comfortable with these competencies and standards. So in addition, we really are reaching out to these groups to try and penetrate the private pay market because we know that the outcomes are so much better for everyone when we get peers working with folks in the system. All righty. So someone who does hold this credential has demonstrated their professional competency by meeting a set of defined standards that measure education, work experience, and supervision. And I mentioned earlier, this is not a point-in-time credential. This is an ongoing credential that's very similar to licensure. So in order to keep your credential, you also need to participate in annual educational events. We require 10 hours of continuing education every year. What we don't do is say what the specific content needs to be because we want our certified peers participating in educational events that mean something to them that will help them in whatever arena they're providing their peer services to move forward. So as long as we can tie the content to one of the core competencies, you're in good shape. The other thing is that all of our certified peers, even though it's a national level, are required to follow ethical and professional standards in the course of carrying out their daily scope of practice. This means that when folks are out there practicing, they cannot have inappropriate relationships with clients. They can't participate in fraudulent activities. They can't take advantage of clients. And if they do, there's now an arm where these folks can be reported, they can be investigated, and an appropriate response can come out. And one of the reasons I think that's so important is that, and again, I've been working in health and human services, professional regulation for, oh my gosh, going on probably 25 years now. And although I believe that the majority of people that work in the fields that we work in are in it because they care about folks and they don't want to take advantage, we all know that it takes one bad actor becoming a headline and then everybody else has this paintbrush of, oh, you must be like those people. And so having this ethical and professional standards that people have to follow to is another assurance to both the public and to other certified professionals that if you have this credential, you really can be counted on to provide professional services in an ethical way, and there is a mechanism in order to respond when somebody does do something that's really inappropriate and would cause harm to the field or to, most importantly, the individuals receiving services. And I think it's also really important that when people go to apply for this credential, they understand that competency is earned through both training and experience. So the fact that somebody has lived experience is incredibly critical to this credential. However, it's also critical that we have training in advocacy, that we have training in mentoring and engaging other people, because nobody's a carbon copy. We have to make sure that our certified peers have the experience to understand what's going on because they've lived through it, and also have training to make sure that everybody's following, broadly the same set of parameters. Folks need to be really aware that if they do something and they get caught, they very well can lose their credential and may lose their job. So it is a really big deal. Again, very equivalent to licensure. All righty, let's talk about what we need. Our qualifications for certification, again, this was set by the group that we mentioned earlier. You need a high school diploma or higher. Second one is current state certification with a 40-hour or greater training requirement or a Mental Health America approved training. You need 3,000 hours of paid or volunteer work experience within the last 6 years, 1 professional letter of recommendation, and 1 supervisory letter of recommendation. And let me go back through the standards and explain them a little bit. The high school diploma or higher is something that was set a long time ago, and the team felt that if an individual is going to come into another individual's world and help them achieve and maintain recovery, at this point in time, a high school diploma is really the minimum that you need in order to be successful in our country. And so the work group members felt like if we have a peer who's coming to the table to get certified and they don't have their high school diploma or GED yet, they really should go ahead and get it before they start working with other peers. And so that's why we set that at the minimum. Current state certification, again, is not even a head tilt, but it is an absolute acknowledgement that state certification is valid. It's an important thing. And so we don't want people to go through additional training when they're trained and have been shown to have demonstrated core competency. What you've got to remember, though, is that almost all state certification programs are at that entry level of core competency, and we're building for the next level. So what I can tell you right now, I looked at a couple of numbers. We've got 54 people who hold the credential, 21 people who are currently approved and preparing to test, and 115 applications in process. And so out of this almost 200 people, we don't have a single person who has come to us without a 40-hour state certification. But if there is somebody who does not hold that certification, they can take a Mental Health America approved training, and we accept that as well. Third bullet is 3,000 hours of paid or volunteer work experience within the last 6 years. Again, what we're trying to say here is that folks that are going for the advanced credential really need to demonstrate that they're engaged in the practice of peer support as one of their primary activities. And so it can be a combination of paid and volunteer work, but we need to see that you're in there more than or about at least half time over a 6-year period. So we want you to be current. We want you to be experienced. One thing I will let you know, and this came up the last time Patrick and I gave this presentation, for the hours, if you're close and you have to go over 6 years and hit 7 or something, please reach out to FCB and let us evaluate what you have, so that we'd rather get you to yes if you're qualified than to say no because it took, you had 3,000 hours in 6.5 years versus 6. So again, please don't self-select out because, as I said in the start, people have lots of characteristics, a lot of experiences. We tried to capture what we thought would be common across the nation, but if you have something that is different but valid, please let us work with you. And then we have the professional letter of recommendation and supervisory. We just like another person out there to say, yes, I've seen Amy provide peer support, and I think she would be great for certification. And someone else that's like, I've supervised her. I really recommend that she seeks this credential. And then once we get there, you are then approved to sit for the exam. It's really, really important to know, though, that nobody will be allowed to sit for the exam until we have approved that they've met all of those standards, because the exam is written for somebody who has those qualifications. So if I let someone come in and take the test who didn't have the experience or didn't have the training, when I'm looking at the performance of the exam, I don't know if it's doing well or poorly because I don't know who's come in. And so that's why we're so hard and fast. I know there's other formats of certification programs that are also very valid and reliable that allow people to test at any point in time. This particular credential was specifically designed, though, for people to have an approved background, and then they get approved to sit for the exam. So like I said, these 21 people that are waiting to test all have an approved application. We've approved their training, their experience, their recommendations, their formal degree, and now they're studying for their test. But again, they couldn't get there until we were sure that they had met the qualifications. Another timeline thing to know is that from the time FCB receives your application and application fee, you get a 12-month period in order to earn approval to sit for the exam. You also have a dedicated certification specialist, so you'll have a person who's been with you and helping you through all of the paperwork and the timelines and everything. If you can't get through it in 12 months, you are able to pay a continuation fee to get additional time. But we try very hard to pair our applicants with a dedicated individual because we know this isn't a common activity. We know you're getting different pieces of paper, different parts, combining them together into an application. So you will have some dedicated assistance. And then once you take the test, you will be certified if you pass it. Actually, since I'm going into CEUs, let me come back to the test. One of the things that we've seen is, we had hoped that we would have more people certified at this point in time. And we did some research across the country. And what we found out is that really one of the biggest barriers was testing sites. And folks did not want to have to drive to an approved testing site and finding a place that's local for folks literally anywhere in the country was proving to be a challenge. So what we now have available, and all 21 people that are waiting to test have been provided with this, is we've contracted with a firm that allows you to take a proctored test at your house, at your office, any place that has internet access and a computer with audio and video. And the price for the exam is the same, but we're hoping that having that as an option for people to sign up and take their test in an environment that's comfortable to them at a time and place that's comfortable to them may really help us get the exam out to people easier. So if you've got any questions about that and the testing, by all means, please feel free to contact any of the three of us on this call, and we'll be happy to share that with you. But that just became live this month, and we're really thrilled and hopeful about it. Couple other things I'll tell you about the test. It's 125 questions. It's multiple choice, and if you receive a passing score on the exam, you move forward, the credential is awarded to you. If you do not successfully pass the exam, you'll get a score report that tells you how you performed in each of the performance domains, and that will direct your studying as you go back to prepare for a retest. FCB does not limit the number of retests that we allow you to take, but we do make you wait 30 days between each test administration because we really want you to take the time to practice and be ready instead of jumping back in. So that is the testing piece. When you do get certified, though, you do immediately pick up some CEU requirements. You need to do 10 per year. And we review CEUs at the time of renewal. This credential is issued for a 2-year period, so we don't check every year for 10, but if you're audited October 31st of your renewal year, you'll be asked to provide a total of 20 hours of CEUs. And as I said earlier, we do accept a broad range of training for CEUs. Any provider who's approved to provide CEUs for other licenses or certifications, all credited college and university coursework, and all training approved by FCB or Mental Health America. I will tell you honestly, it is very hard to find training that is not approved, especially in this space. But we do want people to get training, again, in the areas that they need. For recertification, as I mentioned, the credential does renew every 2 years. And what we don't do is we don't, like say your credential is issued February 3rd, you don't renew on February 3rd. We group everybody into a renewal cycle. So all Mental Health America peer credentials, once they're issued, they will renew on October 31st of whatever their renewal year is. We will send out a notice through email and mail, and it will state that it requires CEU compliance and timely fee payment. One thing that's really important to know is there is not a testing requirement unless your credential becomes inactive and your test score is more than 3 years old. So you would have to let your credential, after a 3-year period, not reinstate it in order to retest. There is no retesting requirement in order to maintain your credential. And I've got my name up here for any questions. Again, what I really wanted to do was to give you some assurance that this was not a fly-by-night credential, that it truly was developed according to national standards and best practice for psychometrics. We believe that we asked the right questions and that there is a valid need for a national credential that reflects the knowledge, skills, and abilities of all peers wherever they work, and to really express to you, too, that we're honoring what came and led to this, accepting all of the stuff that's being done at the state, and helping people move to the next level, and continuing to do that in a professional way where you can count on us to only credential the folks who are prepared to do this safely. So thank you for your time, and I'm going to send it back over to you, Kelly, for any questions that Patrick or I could answer.
Awesome. Thank you both. So I'm going to read some of the questions in the chat, and then folks feel free. We have about 17 minutes, so feel free to add any additional questions you might have. So I have one from Alita, and it says, I'm a licensed marriage and family therapist in Tacoma, Washington, wanting to growing a center of private practice doing open dialogue. I will need to hire a peer because open dialogue requires multiple professionals in the room. I'm hoping to find out in this webinar how fee-for-service outpatient therapists can bill for these sessions. What insurance companies are willing to create billing codes for these services?
You want me to take that?
I believe that's you, Patrick.
Okay. Right now, with the national insurance companies, we are in only the pilot phase where the insurance companies are beginning to try this out on a pilot basis. We're not the only group that's doing that, but over the last 4 years, we've done pilots in Oregon, California, Florida, and we're just beginning a pilot, another one in California and another one in Pennsylvania. So it's not openly paid for through private health insurance yet. The only health insurance that does currently reimburse for peer support across the country, actually there's a few places where they don't do, is Medicaid. So Medicare is a hard one. It's the one we really want to get because more people utilize Medicare than any other health type of funding. And also a lot of people who end up in that peer role wanting to become a peer specialist are people who have been on SSDI, so they've had Medicare, or they possibly have had Medicaid. But right now it's very limited in the number of funders in terms of insurance.
Is there anything I can do to advocate for changing that?
Yes, everything you can think of. It's, you know, we are approaching the health insurance companies directly, and we're beginning now a whole campaign through our policy department to work with states and to work with the federal government to get wider recognition of peer support so that there is additional funding. The health insurance companies are probably more open to it than Medicare. Medicare is, you know, it's a government agency, it's a very large bureaucracy, and it moves very slowly. Health insurance companies are not lickety-split, but at the same time, they're interested in providing proven services that work, and they're also interested in providing services that are not as expensive. And, you know, when people receive peer support, their need for much more expensive services generally goes down. By the way, I really want to tell you how much I'm just thrilled that you're doing open dialogue. I think that's wonderful, and I'd love to hear more about that as it goes on. But anyway, that's basically where we are now.
Well, thank you so much for putting this together, and I wanted to say that there's a training in Tacoma coming up It's a year-long training. It starts in April, and you can go to opendialoguewashington.com and find out about it and tell other people about it, because we need peer professionals, psychiatrists, everybody.
Hello? Hello?
Yes.
Yes, my name's Otis, and I'm out here in Wisconsin. I'd like to thank Patrick and Amy for assisting me in getting my national certification back in April. You know, we did a lot of emailing back and forth, and finally I was able to take the test, and I passed it. But I'm the executive director of Great Lakes Dry Hooch also. And we're a peer support unit, a veterans peer support unit out here in Milwaukee. And I guess my question is, over the last, I'd say 6 or 7 months, maybe a year, I've noticed that at some point, an organization has been offering some online peer support employment. And I'm wondering how that works.
Could you explain that just a little more?
Well, I understand. Like I get the Mental Health of America newsletter, and that newsletter, it has some job opportunities where you can actually do some online peer support. You know, where I guess there's agencies that will employ folks to do online peer support for them. Does anyone know anything about that?
When you say borderline peer support, what exactly do you mean by borderline?
No, online peer support.
Online. I'm sorry. I misunderstood you completely. It's a lousy connection. We're not doing online peer support yet, but it's really growing rapidly. And we've been approached by several different online companies over the last 2 years about being able to hire people with our certification. So that's going to be one of the fastest growing areas of peer support, because we have all kinds of issues about people having access to services. Certainly any rural community, it's difficult. You know, in the frontier states, the western states, it can be hundreds of miles to the nearest community mental health center. And then we also have individuals who, through their own situations, tend to isolate themselves, maybe have issues of being in, around crowds or strangers that they don't know. So I see online as really a major part of the future of peer support. I don't think it'll ever replace face-to-face peer support, in my opinion, and maybe it's because I'm so old, but in my opinion, face-to-face is really the most effective. But online is going to find its way, and it's going to be tremendous. Okay.
One last question. When we talk about mental health approved training instructors, how do like I am a national now certified peer support person, okay? And I'm wondering, in terms of opportunities, what's that next step for the person who is a national certified peer support person, who's actually gone through the course and passed it? What's their next opportunity in this space?
Well, not through the certification, but the very fact that you got certified with the national certification means that you've been through a really good peer support training program. And I know Wisconsin's had more than one over the years, but they've always had really high-quality peer support that I've been aware of. So the opportunity is to, when we say MHA approved, I think we currently approve, I believe it's 6 or 7 different courses, but it's growing fairly rapidly. It may be even higher than that at this point. Kelly can better answer that than I can. But what we're looking for is peer support courses that really address all the components of our certification. We know that, if you went through a 40-hour training and then you didn't have any work experience, you would not be able, probably, most likely, you would not be able to pass our examination. But if you went through a 40-hour training and then you had 3,000 hours of experience, you probably could pass our thing. There are other trainings that go up to as high as to 105 hours. So, and in fact, there's one I think that's even higher than that now. But to work with the training organization that you got your training from, to take a train the trainer course so that you can become a trainer in your own right. And obviously the training you went through was sufficient for us.
Yeah, the state certified. I guess, Patrick, my last question is this. Like I said, we're a veteran organization, nonprofit called Great Lakes Dry Hooch. And we also, we've worked with the Medical College, Marquette, the VA, and also MHA. We're also partners with MHA out here in Wisconsin. And we've created a QRF manual, okay, a veteran peer support manual. Okay, it's 5 years of making, and it's out here now. And we're wondering what exactly do you do with veteran peer support classes or courses or veteran peer support being in that space? Are you in that space at all to assist, to help in terms of collaborations, partnership, approval maybe of our instruction manual?
You know, it's a complex question because I've worked with the VA itself on peer support over the years. I'm not a veteran, so I cannot be a VA-approved peer specialist. That's held solely for people who are veterans. Right. But I've worked on developing a homeless outreach peer specialist course for the VA, and it's been implemented in a number of places around the country. Our certification doesn't meet VA standards because it isn't directed at veterans. Now, if you're a veteran and you've already been through a state certification, you're already eligible to apply to become a VA peer specialist. You're talking about your state program, which sounds really, really cool, really fascinating. I would love to see like an outline of what you guys are doing, and it may be that we can say that that's an approved training too. But I suspect everybody who goes through your training probably gets certified in Wisconsin anyway.
Not absolutely, though. But actually, what we're doing is we're in the process now of getting our veteran peer support course certified in the state. It hasn't been certified yet, but I would welcome the opportunity to send that manual to you, and take a look at it.
Absolutely.
Okay.
That'd be wonderful.
Thank you very much.
Thank you.
Thanks. So we have time for a few more questions. There's one I can answer really quickly from Susan Crane-Lewis, and she said, is the new remote proctoring replacing MHAs as test-taking sites? So the existing approved testing locations through MHA affiliates are still available for folks who want to take the exam in person, but for folks who either those times don't work with their schedule or aren't near a testing site or for any other reason can't make it to one, we're also offering the online training. So you can see on FCB's website at nationalpeerspecialist.org the list of MHA-approved training sites if you're near one of those and would like to take the test in person. Let's see, I have a question from Lauren that says, I got my peer support certification in July 2018 and work full-time in a peer-run organization. But I have a master's degree in social work and have been working on a behavioral team since 2014. Does that count towards the hours?
Hi, this is Amy.
Go ahead, Amy.
Yeah, I think that we would have to look at your specific work experience to see what we could transfer. Anything, what I'm assuming is that you've been working full-time in a peer-run organization since 2018, which would give you right about 7 months. We would have to see exactly what your work on behavioral teams is. My knee-jerk reaction is probably not, and it's only because we've got lots of folks that are very, very talented clinicians, but the actual delivery of peer support is part of what we're measuring with this. And so we do require that the 3,000 hours is related to actually delivering peer support, versus administration or other things in that. But what I would do is really encourage you to let us look at your history, your position descriptions, and then we'll be able to give you a more specific answer. Would you add anything to that, Patrick?
No, that's what I would say.
Awesome. So I have a question from Sharon that says, how does peer support work in terms of offering healing to those affected by pregnancy loss?
Affected by what, I'm sorry?
Pregnancy loss.
You know, this is a really growing area of peer support, and there's a couple of organizations around the country, not just pregnancy loss, but also issues of motherhood in general and postpartum and prepartum depression. And so, I mean, this is really rapidly growing, and we're not the experts on it. There is a wonderful group called Moms 2020, and you can find them just by Googling it. And I know they're doing a lot of work in creating trainings for people to work specifically in this kind of space.
Okay, I have a question from Antonio who says, how does one get a website testing appointment? I have requested to get the information for the online exam.
Antonio, if you're talking about the CRPS, the national exam with Mental Health America, that request comes through once your application has been approved. So we won't be able to get you that information until we're certain that you've met all of the requirements. But what I can do too is pull you up in the system, see where you are in the process. And if you're one of our 21 waiting to test, I can take care of that immediately. And if you are in one of the applications in process, I'll let you know exactly what you need to do and get you taken care of.
Awesome. All right. Well, we are at 4:30. One final question. So Antonio said, also, what are you doing for folks that English language is not their first language?
That one's a tough one right now. Right now, the exam is only available in English, so we have not had the demand yet to have it translated into Spanish. So that really is not something that we have addressed to date.
Right, and it is something that we're, aware of the need. In fact, the need is great, but, we're still building our credential. We're, a little less than 2 years out with it, and that will be one of our upcoming projects, I think, in the next year to 2 years.
Yeah, I think you're right, Patrick. Just for the group to know, like I said, it was 2006 when I first met Patrick, and we started developing the exams that we use in Florida. And just this week, we received the Florida version of the Certified Recovery Peer Specialist exam in Spanish. So we'll be doing that for the first time in Florida starting probably next month. And that's going to give us a lot of lessons learned for when it's time to bring the MHA exam into that second language.
Awesome. So Antonio also noted not only Spanish language, but other people that can only express themselves in the language they're most comfortable, and said that he's been approved to sit for the exam. So if you wanted to, Amy's email is on the screen right now. If you want to email her directly, and like she mentioned, she can get you set up. Since we started a little bit late, I'll throw out one last question for you, Amy and Patrick. So Lisa says, how does a private peer support provider secure state supervision requirements?
So you're talking about a private practitioner or somebody in private practice, and then how do they meet state supervision requirements? Right now, in the states that I've been doing these special projects in, no state has, no private practice has required state certification. It's a qualifier. It will qualify you for many jobs, but it's not a requirement. So right now, because private practice is not really well versed in providing peer support, let alone hiring people to work in peer support, it's got fewer rules, and the main problem with it is just that it moves so slowly. So in other words, for instance, when we work with Kaiser Permanente, or we work with, this one big hospital corporation that we work with to do these pilot programs, they did not require the people working in those programs to have the state certification of the state we were working in. They just required that they have training and then get our certification. Everybody we ended up hiring for those projects actually did have state certification, but it was not a requirement. So there was no requirement for state qualified supervision either. And it probably will be that way for a while until the private sector really begins to sort this out and figure out how it works best for them.
Right. And this is Amy, I would throw in too, if you're looking for someone who can provide you with the supervision necessary for a state credential, I know I can only speak specifically to Florida because Mental Health America has the work experience requirement but not the supervision. I do know that there are a slew of folks out there who put themselves on the private market as, for lack of a better term, supervisors for hire. And I know that's used a lot in the licensing world. My caution to you guys is if you do decide to do a supervisor for hire, I'll be glad to send you what FCB requires in terms of supporting documentation from anyone that's giving supervision for certification purposes, which is a little different than I think what you're asking in the question, but I wanted you guys to know that that is a possibility as well.
Yeah.
Awesome. Well, it looks like those are all of the questions we had. So thank you, everyone. Thank you, Patrick and Amy, and everyone who joined us and who's still on the line. Just a reminder that the recording will be on the website along with the slides. And any questions you have moving forward, you can address to Patrick, Amy, or myself.
Thank you, everyone. We really enjoyed it.
Thank you, everyone. Thank you for hosting and coordinating us, Kelly.
Thank you.
Bye, everyone.